Hello and welcome everyone. Thank you for joining us for today's webinar. My name is Hannah and I'm the Office Coordinator for the National POLST Paradigm Office. Today we are presenting the overview and introduction to the POLST Paradigm Toolkit series presented by Amy Vandenbroucke, Executive Director of the National POLST Paradigm Office. Just a couple notes before we start. We would really like to hear from you, so if you have any questions at all during the presentation, please type them into the chat box. We'll get to your questions during the webinar and also at the end. Also, the webinar is being recorded and it will be available at polst.org later today. And now, without further ado, I'd like to turn the time over to Amy.
Hello, and welcome to our first webinar in the series on our using the POLST paradigm to honor patient treatment wishes across the Care Continuum Toolkit. Through an overview and 5 chapters focused on the different healthcare settings listed here, the goal of the toolkit is to help facilities implement appropriate POLST paradigm processes that support the patient throughout transitions of care. We hope to emphasize that none of these facilities is isolated when looking at POLST form, but need to appreciate that a patient may come in with a POLST form and leave with a POLST form, and that the processes and policies they put in place need to support the patient as they transition across care settings, not just while they are in that facility. To use the toolkit, we recommend reading the overview before any specific chapter. The chapters were written by professionals in those facilities. We tried to use the terminology found in those facilities and really focus on the actual processes. Because the POLST paradigm programs vary by state, the toolkit was written generally. We try to provide resources that anyone can take and tailor towards their facilities. There are many resources in this toolkit, but also beyond, that can help. We strongly encourage anyone wanting to implement POLST in their facilities to connect with their state program. The toolkit itself will be posted online at this website at the end of April or early May. You can find the toolkit online on the professional side under Resources. This webinar is the first in a series. You can sign up for free of charge on our website. In this webinar, I will provide the overview of the POLST paradigm, our history, how POLST differs from other advanced care plans and documents, the value of POLST for patients, and our organizational structure and resources. This webinar serves as the base for the rest of the webinars, which will focus solely on the POLST paradigm within those facilities. Please feel free to put questions in the chat box at any time. There will be an opportunity for questions afterwards, and you can also contact us at any time. Our contact information is online. Max's story, which you can find on our website, is an example of why POLST is needed and why an advanced directive isn't always enough. Max had clearly documented his decisions about the treatment he did not want after being diagnosed with a progressive heart condition and an advanced directive. But when he collapsed as a result of that condition, EMTs were unable to honor his wishes because they were not documented in a medical order. Max's death would have been very different if the responding EMTs had had a POLST form to direct the course of his care. It was hearing stories like Max that in 1991, leading medical ethicists in Oregon recognized that advanced directives were inadequate for the patients with serious illness or frailty, like Max, who frequently required emergency care. They realized that patient preferences for end-of-life care were not consistently honored, so a group of stakeholders developed a new tool for honoring patients' wishes for end-of-life treatment. After several years of evaluation, the program became known as POLST. POLST stands for Physician Orders for Life-Sustaining Treatment. The POLST paradigm is a process that includes a brightly colored portable medical order. Most states use some shade of pink. The POLST form is a portable medical order designed to support patients transitioning between facilities or who live outside a facility by communicating patient treatment wishes. In the event of a medical emergency, when time is of the essence for medical decision-making, the POLST form serves as an immediately recognizable order set in a standardized format to aid emergency personnel in implementing patient treatment wishes as communicated to and documented by the patient's healthcare professional, provided after a shared decision-making conversation. Not all states use the term POLST. These other terms here are used instead, but they are all part of the POLST paradigm. The fundamentals of these programs are the same, but states create little tweaks based on the values, culture, and society within each state. I'm going to use the term POLST in this presentation, but what I say applies to all POLST paradigm programs. For reference, most states have some level of POLST paradigm development. As a note, Arkansas passed POLST legislation this year and will be listed as developing once leaders there have met with our Developing State Assistance Committee. This means that the POLST paradigm exists at some level in 49 states and Washington, D.C. To make sure we are on the same page, there are 3 categories of advanced care planning. Our standard of care is that emergency personnel are required to do everything possible to attempt to save someone's life during a medical emergency unless there is a medical order to the contrary. If you do nothing, this is what you get. Second are advanced directives. These are called different things in different states, but they are all legal documents. You use them to provide your general treatment wishes for unknown future medical crises. You also use them to identify a surrogate or someone who can speak on your behalf when you become incapacitated and cannot speak for yourself. Third are medical orders. These are do not resuscitate orders and POLST forms. These are the documents that EMS can follow during an emergency. Often, there is confusion between advanced directives and POLST forms. The most fundamental difference for patients is that EMS can follow a POLST form since they are medical orders. The other key differences are on this table and on our website. Advanced directives and POLST forms work together to help ensure patient treatment wishes are known and honored. Every adult should have an advanced directive. It is only later when a POLST form should be considered. The question, would you be surprised if this patient died within the next year, was developed in the early 1990s and has been shown to be effective for helping clinicians predict which patients with cancer were nearing the end of life. This is what we used for determining if POLST is appropriate for a patient. POLST forms are intended to be used by those who are seriously ill or frail towards the end of life. In other words, those individuals who are at the greatest risk of having a medical emergency, but who may not want our standard of care. There is no need for a diagnosis of being terminal. That's something neither healthcare professionals nor patients want to have to do or hear. This specific population is because POLST form orders are for what the patient would want tonight. Healthy individuals would want full treatment. There isn't a question on this. Instead, it is only when a patient has a diagnosis and a prognosis and can have a thoughtful conversation about the various treatment options, such as ICU care or intubation, and what that would mean for their condition and their quality of life, that a POLST form should be completed. Some common questions we get are around the intended POLST population. First, just because a patient turns a certain age, like 65, doesn't mean they are automatically appropriate to have a POLST form. Many 65-year-olds are too healthy for a POLST form, but should be encouraged to complete an advanced directive if they don't already have one. Similarly, just because a patient enters into a facility, such as a nursing home, doesn't mean they are automatically appropriate for a POLST form either. POLST forms can be used in pediatric populations, except in Colorado. For patients with significant disabilities, healthcare professionals need to consider whether the patient is truly appropriate for POLST. Here are some questions to use to make that determination. You can also find a guide specifically about using the POLST paradigm within this population, created by the Oregon POLST Task Force, on our website. Most POLST forms, Section A functions as a DNR order but goes further. A DNR order only provides evidence that the patient does not want to be resuscitated in the event of a cardiac or respiratory arrest. In contrast, a POLST form allows a patient to confirm they actually do want CPR attempted, or they can refuse an attempted resuscitation. Further, and this is important, DNRs give a very limited information about patient treatment wishes. If the patient is responsive, has a pulse, or is breathing, It is useless in an emergency situation because the question is no longer whether the patient wanted to be resuscitated, but rather what level of treatment and what other medical interventions the patient wanted or didn't want while in a medical crisis. Completion of Section B of the POLST form provides direction about treatment wishes to emergency personnel in situations short of full cardiac and respiratory arrest. This is important because the literature indicates not all people who complete a DNR order want the same level of treatment. In fact, about 50% of persons want to stay where they are and receive comfort measures, and 50% prefer to go to the hospital. So if a patient is only using a DNR or only has Section A completed, EMS would want to bring those in a medical emergency but not needing CPR to the hospital, which is something half of these patients do not want. To harness the full value of POLST and to fully document and protect patients' treatment wishes, both Sections A and B should be completed. So when a patient is in medical crisis but does not need CPR, the real value of POLST comes into play. The heart of a POLST form is in its Section B, which offers 3 levels of treatment options. Full treatment, which means the patient wants our standard of care, everything possible, including ICU care and a breathing machine. Limited treatment or selective treatment. This means the patient wants to go to the hospital if necessary, but prefers to avoid the ICU and does not want to be hooked up to a breathing machine. And third, comfort measures only. The patient would prefer to stay where they are and have their symptoms treated. Conversation is the cornerstone of the POLST paradigm. The POLST form is only as good as the conversations preceding it. And the POLST form is a step in a process that includes, and in fact depends on, a conversation. The form is designed to document treatment decisions made after shared decision-making conversations between a patient and his or her healthcare professional about the patient's diagnosis, prognosis, treatment options, including the risks and benefits of each, and what the patient constitutes as an acceptable quality of life. Using all of that information, the healthcare professional and patient work together to make decisions about desired treatment. The result may be the completion of a POLST form, or it may simply be a care planning discussion documented in the patient's chart. If a POLST form is completed, then the healthcare professional completes and signs a POLST form. The original copy of the POLST is given to the patient, and then the healthcare professional puts a copy in the patient's medical record. If applicable in your state, you may be required to send a copy to a registry. A POLST form is not a one-and-done document. The POLST paradigm recognizes that things change over time, including a patient's prognosis, health status, what constitutes an acceptable quality of life for the patient, treatment options, and preferences for treatment. The POLST form is intended to be dynamic, reflecting the patient's current wishes about the medical treatments he or she wants to receive. This dynamic process is achieved through ongoing conversations when a POLST form review is completed, during appointments with a healthcare professional, upon changes in level of care, changes in location of care, especially upon admission and discharge, and changes in the patient's goals of care, treatment preferences, or what constitutes an acceptable quality of life. While full treatment is also our standard of care, for patients who are seriously ill or frail, they may use a POLST form to emphasize that this is the treatment level they want to receive. This can help alleviate surrogate burden or any confusion among family members or clinicians about what the patient wanted. However, since prognosis and quality of life and patient goals of care may change, all POLST forms are easily modified. A patient may start wanting full treatment, but if their prognosis worsens or their quality of life is horrible and not likely to change, they may wish to choose limited treatment. If things get better, for example, a clinical trial offers them hope, then they may wish to change back to full treatment. Or if their prognosis worsens, a patient may choose to have comfort measures only. A patient's wishes for these treatment orders can change over time. 15% of POLST forms each month in Oregon are revisions. And of course, a patient may choose to void their form at any time. I want to emphasize here how a POLST form medical orders bring advanced care planning upstream during an emergency as compared to our standard of care or traditional advance directives. The patient has an emergency and EMS is called. Everything is done in an attempt to save the patient's life, and they end up in the hospital in the ICU. At that point, when the patient is stabilized, then the healthcare team looks at the advance directive if one exists. They identify the surrogate, and together, the healthcare team and surrogate use the general treatment wishes provided in an advance directive to inform the plan of care, either a lower level of care or still in the ICU. With POLST, however, things change. The patient has an emergency and EMS is called. EMS reviews the POLST form, and if it says comfort measures only, the patient will be treated where they are. There won't be any trip to the hospital unless the comfort cannot be managed where the patient is. But even if the patient does need to go to the hospital, staff there will be able to see the patient's goal is to be able to get back to where they were. Otherwise, the patient will be transported to the hospital. If they wanted limited treatment, they'll go to the hospital but not be in the ICU. And if they wanted full treatment, they will get everything. Some key points to remember is that POLST form completion is voluntary. Just as it is not required to complete an advance directive or receive health care, patients should not be required to complete a POLST form. POLST forms can be changed or revoked at any time. POLST is about what treatment the patient does or does not want. Comfort is always provided. POLST forms are signed by healthcare professionals after a conversation. These forms are medical orders. Healthcare professionals must sign them in order for them to be valid. Additionally, all POLST forms have an attestation or statement that the healthcare professional is agreeing the orders reflect the patient's wishes, and those treatment wishes cannot be known unless a conversation has taken place. The type of healthcare professional who can sign varies by state. The POLST paradigm has a lot of value to offer to patients. Lee's story demonstrates how POLST can be valuable for a patient's peace of mind and giving one last gift to their family. Lee was 54 years old, married to her husband Rick for 30 years. After fighting her cancer for almost 8 years, Lee was at peace knowing she was dying. One of her greatest concerns, and one of the last gifts she could give, was to ease the burden of decision-making about her medical treatments for Rick and her family. She had been through 20 surgeries, but there was nothing more that medically could be done. She didn't want to go through the pain of EMS attempting to save her life when the inevitable medical crisis came. Quoting Lee, "I want to die at home with my family around me. To me, that's going to be the most comforting, peaceful way to go. I don't want to go to a hospital. I want any medical intervention to be minimal, and I want it to be at home." Lee used a POLST form to communicate her wishes, and she was able to die at home with Rick and her 2 children. The fact is, POLST is effective in helping people like Lee die where they want. In 2014, the Journal of the American Geriatric Society, JAGS, published a study showing the strong connection between POLST form orders and where people ultimately die. This article, and another one published in 2016 comparing West Virginia data as well, demonstrates that the POLST form orders are honored. This chart shows the results of reviewing 18,000 death records of individuals with valid POLST forms in the Oregon POLST Registry who died of natural causes in Oregon between 2010 and 2011. Researchers compared those individual treatment wishes with their location of death. Without a POLST form in the registry, individuals had a 34% chance of dying in the hospital. The other 3 bars demonstrate the value of POLST compared to that baseline. When orders are marked for comfort measures only, it means the patient did not want to go to the hospital. Only 6.4% of patients with a POLST form ordering comfort measures only ended up dying in the hospital. Likewise, if the patient wanted full treatment, they were 30% more likely to end up dying in the hospital than the baseline. Essentially, you get what you want. No other tool has shown this level of effectiveness, and this data is compelling to states wanting to develop a robust POLST program. I'll take just a minute to describe the structure of the national POLST paradigm. Each state builds its own coalition to implement the POLST paradigm by developing their own program, either through a grassroots approach or through legislation or regulation. The approaches vary. All states considering or actively developing a POLST program are encouraged to participate in the national POLST paradigm. The national POLST paradigm is the name of our organization, but it represents the ideals of any POLST paradigm program. The national POLST paradigm works like a collective impact, where all participants have a shared vision for change and work to build consensus on strategies. The task force and the National POLST Paradigm Office serve as the backbone of the initiative and coordinate guidance, research, education, policy, and quality assurance for all POLST programs to follow. A key recommendation from the Institute of Medicine's Dying in America report is to encourage states to develop and implement a POLST paradigm program in accordance with nationally standardized core requirements. The task force is the nonprofit entity that sets those core requirements and works to ensure that individuals with serious illness or frailty not only have access to POLST forms, but to professionals who understand the value of the POLST paradigm and are trained to have meaningful goals of care conversations to elicit, document, and honor patient treatment wishes properly through a POLST form. Otherwise, no federal rules or regulations explicitly mention POLST. This means states participating in the national POLST paradigm help shape the standards, requirements, and appropriate use. The more consistent we can all be in implementation, the stronger and greater the integrity of the paradigm overall. I want to wrap up by pointing out some commonly used resources available to everybody on our website. Thanks to grants from the California Healthcare Foundation and the Retirement Research Foundation, the website was updated last year and has more information on it than before. We added an archive of all of our newsletters. You can sign up to receive this monthly email in the footer of our website or by clicking on News. We have a page dedicated to patient stories, including Lee's and Max's stories, which were both filmed by the Oregon POLST Task Force. In the same section of the website, we have our other recorded webinars. And the National POLST Paradigm Task Force doesn't have many policies, but you can find what we do have online. For many states, having our legal resources, such as our legislative guide and a regulatory and legislative comparison of state programs, is helpful. And for those involved with our state coalitions or task forces, we have a forum available to get more information, ask questions, and learn more. This project was funded by the Retirement Research Foundation and launched last fall, and we encourage anyone interested in POLST to connect with your state program and reach out to us for access to this forum. Thank you. Please be sure to join us for our other webinars. Registration is free. You can sign up online, and we will also have these recordings available afterwards. Again, the toolkit is expected to be posted by the end of April or the beginning of May. So I will take questions now. Hannah, do we have any?
Yep. I do have one question for you. If a patient chooses full treatment, why would they complete a POLST form?
If a patient is within the population that would likely have a POLST form, again, someone who is seriously ill or frail, and there's a question about what treatments the patient may want, having the patient complete a POLST form for full treatment just emphasizes that the patient has thought about this and they do want our standard of care. It alleviates any surrogate burden that the patient may want a lesser standard. So it's just an opportunity for the patient to reaffirm that that is in fact the treatment that they want, especially when they have a condition that might raise that question.
Okay, great, thank you. Another question that came in, what is the purpose of the registry? Can a POLST be fully implemented without being registered?
Yes, so very few of our states actually have a registry, and the purpose of the registry is really to have one place where POLST forms reside, and it just helps make sure that emergency personnel have access to the form during an emergency. In states without a registry, we just need to remind patients that they need to keep a copy of the POLST form on them at all times so that EMS knows what orders that they want. The registry is just an opportunity for patients to not have to carry those orders around with them, but EMS to still have access to the orders so that they can follow and honor the patient treatment wishes. We'll have more information on the registries on our website within the coming months. If you wanted more information, certainly feel free to reach out to us. we do have some reports on registries currently in our library. If you need access to those, we can provide that.
Another question that just came in, can a family choose to make changes to a POLST form once the patient has documented their wishes and become incapacitated?
That's where the importance of an advance directive comes into play. An advance directive identifies who the patient wants to make decisions for them when they become incapacitated, and that person is usually called a surrogate or a proxy. In some states, that can also be designated by law. Not all states have a statute, though, saying who gets to legally speak for the patient if they no longer have capacity. So when the patient lacks capacity, we look to that surrogate or proxy to make decisions, and that includes updating a POLST form. There are a couple of states that have limitations on that, where the patient would have to check a box specifically authorizing the surrogate to be able to make edits to their POLST form. And in some states, if the patient has chosen DNR, that can't be undone by a surrogate. So state law varies, but we would be looking to the surrogate to be making any changes to a POLST form, because the surrogate stands in the place of the patient when the patient lacks capacity to make healthcare decisions for themselves.
Great, thank you. Another question. It seems there is a culture of expecting a POLST whenever someone is admitted to a skilled nursing facility. Comments on how to change this?
That is certainly a perennial problem that we've been hearing, and that was part of the impetus of this toolkit, is to help reinforce the idea that this is a conversation. A POLST form should not be included in an admissions packet for the patient to complete. It shouldn't just be handed to the patient. You really need to have a thoughtful conversation, and this is a document where the language on the form itself is intended to communicate between healthcare professionals. So these forms are not friendly to patients, and that was because this is a medical order communicating among medical professionals. So we are hoping that this toolkit is one of the ways that we can help reinforce that POLST is a decision that the patient makes. It's based on thoughtful conversations, and that not everybody everyone needs a POLST when they enter into a facility. A facility can have a policy that it's mandatory to offer a POLST to individuals, but it should never have a policy that requires it. Patients have a choice on whether or not to have an advance directive. They have a choice on whether or not to receive care. They should have a choice on whether or not to have a POLST form completed for them. So it should always be voluntary. So we'll emphasize that in the toolkit. We have a policy that will be coming out later this month from the National POLST Paradigm Task Force that further emphasizes that. And then there are resources in our library. Some states, for example, Oregon, has created with their Department of Health Services guidance to facilities, specifically reminding them that POLST is optional, it's voluntary, and it should not be required. So the more education we can get out and the more we can help people understand that this is voluntary, the more that we can undo that the fact that some facilities seem to be requiring it of patients entering their facilities or as a condition of admission, because that should never be the case.
Okay. I have another question for you on healthcare proxy changing a patient's POLST form. The proxy can still make changes in our state, unfortunately, even if it is against the patient's wishes. Would this mean the family could also reverse the decisions previously made on the POLST once the patient is incapacitated?
So this is where the importance of helping the patient pick out a surrogate or a proxy is important. We're working with a couple of state leaders to try to put guidance on our website, and I know other things out there like Prepare for Your Care focus on picking a surrogate. Too often people just pick maybe their husband or their wife, not thinking or having a deeper conversation about how the person will incorporate the patient's values into any decisions that need to be made. So first, we can do a great service to our patients in just helping them identify the right surrogate, who's the person that's most likely to honor the patient's individual values and goals and not their own. Regardless, if the patient has picked out a surrogate and that surrogate or proxy doesn't seem to be acting in the best interest of the patient, I would encourage you to get your social workers involved and possibly even call an ethics consult. It's a struggle and it's a challenge for surrogates to really understand their role sometimes, and we as healthcare professionals can really help them recognize that it's not what they would want, but it's really what the patient would want. And the more documents that the patient has about wishes, be it in an advance directive, a POLST form, or even the chart notes from conversations between the patients and healthcare professionals, the more evidence we have of what the patient would have wanted, the more that we can hopefully get the surrogate to understand that we want to honor the patient's wishes and help them get to that point and not undo what the patient has wanted previously.
Great, thank you. A question on having the conversation with the family and patient. Are nurses the only healthcare provider other than the doctors that can have the conversation with the family? Or can social workers be trained to facilitate the POLST conversation?
There are different elements of the POLST conversation. It's not just a single conversation, but it can be made up of multiple ones. And I certainly encourage facilities to think about who would be the right person to work with the patient and their loved ones, if appropriate, to help make decisions. And that may be training chaplains and social workers and other members of the healthcare team who can't sign a POLST, but who may be able to have a conversation with the patient, getting them comfortable, for example, with their diagnosis, helping them come to terms with what that means for them, helping them think about and work through what do they value in life, what do they want to get out of their treatment, what is an acceptable quality of life for them. And with that framework, that might make the patient more open or ready to discuss the more intricate medical details about what the treatment options truly mean for them and how they impact their quality of life. So the POLST conversation, really, I encourage people to think about who needs to be involved, who should be trained, and how we can best work to support the patients to help make sure they really make the right decisions for themselves. This is a tough conversation. So again, it may not be one, it may be multiple, but what are the different people we can use and what are the different tools we can use? You know, what brochures do you have? We have a lot of resources on our website, and many programs are willing to let you take those materials and modify them as you need to. What are the different videos that you might be able to use? On our website, again, we have a number of videos that can be used for training purposes. So be broad, let's focus on the patient and how we can best get the patient to a point where they can make good decisions for what their situation is. And the more that we can include family members, with the patient's permission, of course, in that conversation, the better off we are and the more likely we are to avoid the situations we were just talking about in terms of having people override patient decisions.
Okay.
And I'll
Great,
just
comment,
I appreciate Pat's comment that a team-based approach to the POLST discussion can be used but must be done in scope of practice. That's absolutely true. And of course, again, who can sign a POLST form varies from state to state, and that also must be within scope of practice.
Okay. There's a question on if a patient has a pacemaker and does not wish to be resuscitated.
I'm not sure if we're talking about a patient that's within the intended population, but you know, if they're seriously ill or frail, and we wouldn't be surprised if they died within a year, then yes, they can certainly use a POLST form to comment not only on the DNR if they don't want to be resuscitated, but again, what they want to have happen if we're not talking about resuscitation, but they're still having some sort of medical crisis, what's the next level of the treatment that they want?
All right. Thank you, Amy. It looks like that was our last question. If anybody else has any other questions on the toolkits, you can email us, toolkit@polst.org. The recording will be available later today on our website. And yeah, please reach out if you have any other questions.